All right. I was just like, I want my
Okay, so,
What's in my chair?
I don't know if this thing is locked. So, did everybody find the central fault? Did you find it? Do you have, well, we could do more with it, but I mean, I want to show the globeller fault because I want everyone is going to test each other for globeller faults so we can fix some globeller faults. What is the signature breath-wise to a globeller fault? Nose respiration, nose or oral, but not both. Weakens, it will weaken to, actually I'll back up a little bit. Often what you'll find is a strong muscle in a weak muscle strengthens to a breath in through the nose or orally, but not both. You can also take a strong muscle and test it against oral versus nasal respiration. That's the signature thing around globeller. Globeller is basically the skull is kind of squished this way. A lot of times there's bilateral temporalis involvement. And it kind of squishes this way, and the skull kind of elongates. That's one of the reasons it's believed that it increases blood pressure. The nervous system senses that it needs more pressure to get the blood into the head. And so it'll raise the blood pressure to try to get the blood there. Brain is the highest consumer of oxygen, and so it gets top priority as far as blood. So I'll start with a strong muscle. Now breathe in through the nose, out through the nose. Breathe in through the mouth. And breathe out. I breathe in through the mouth. So that's where a strong muscle will weaken. Do you have any weak muscles? Oh, you had SCM.
No, I had scaling.
I mean, scaling.
Yesterday.
Yeah.
Mm-hmm.
Still have it. Breathe in through the nose. That strengthens. Breathe out. Breathe in through the mouth. So there, we verified it from weak muscle and from strong. That makes sense. Now, how do I TL for globeller? How do I have the patient TL? One way. Two-handed TL, but two-handed TL. Now I got to use a different muscle. Yeah, take it away first. So get a baseline. Okay, so we get a positive TL. Breathe in through the nose. Hold the breath. Breath in through the nose negates it. So that's just another way to go. So my correction is going to be the same thing. It's going to be pressing those 2 points while she breathes in and out through not the mouth. So she breathes in and out through the. So you do the correction on the phase of respiration that they didn't weaken. So breathe in through the nose, out through the nose. Make sure they breathe out through the nose. Right there. Feel it starting. So you also have temporal. Now I'm putting 5 pounds of pressure So the right serratus was the out through the mouth, in through the nose, out through the nose. That's totally back on. Who knows what else is going on, but that made a difference. Difference out through the mouth. So now those muscles are not affected by nasal, oral, in-breath, out-breath. And that's ideally, muscles shouldn't be weakened or strengthened by breath in or out or nasal versus oral. Everything is kind of balanced and kind of calibrated well. Our muscles should be able to operate just fine without depending on breath in amps up the neurological activity in the body. It increases the intrathecal pressure. It like gives us that extra push. But in between, if there's not enough fluidity in the craniosacral system, in between the breaths, that's when we get weak. So the last part of this, which I call, I never do this together, but the way that they like us to teach it is, I'll do 3, 4, 5 inspirations like this, and then the last 2 or 3, it's hard to do unless you're hit your fingers. Sure. Head down here. Actually, head down there would be good. This is going to be interesting.
We adapt and adjust.
This is what I find is that I would say I have my right hand on her occiput doing the cranial adjustment, like so, right? The idea is you put these 2 fingers on the ELP to kind of get some traction there, and then these fingers are on the top 3 vertebrae, sort of spreading them as you go. Now, what I do is I'll do this correction, and then I go in through here like this, and then I'll just get in on the right, have you breathe in. I'll just give them a little individual segmental traction.
So you're just creating space.
What's that?
You're just creating space.
Just creating space. But the way it's like, where is that skull?
I have lots of skulls.
Lots of skull. We got skull. So my fingers would be like this on the skull, and then these would be, actually I only have 1 finger to put on, and then these would be on the neck like this. And you can see why I find it difficult to do. Now, if somebody with really big hands could put it off. Want to make sure that the upper neck, because after this has been crammed, the upper neck needs to be. That's the glabellar fall. So what I'd like us to do is just start with a strong indicator muscle. Have your patient breathe in through the nose, out through the nose. Test them. Breathe in through the mouth. Well, test them as they breathe in. In through the nose, test. Out through the nose, test. In through the mouth, test. Out through the mouth, test. Look for weakening. If you find weakening, you've got to go that way. Fix it. They're much more common than you might think. So, and then if you didn't quite finish the sutural thing, we'll make sure that everybody gets that.
At the other end, if you push it up.
I clearly never so reset correction. I know one.
Okay, so did he explain it? So
What is it? Inhale.
So you find it like, you know, we're talking about so you find ITL, and then patient TL again, and then you go and push it together, test the muscles. Pull it apart.
I love this block.
Pull it apart if it makes muscle apart, muscle goes breath damage. You correct it, pulling apart.
Yeah. Okay. So you have to test and then breath first. If I have it, it's better.
Well,
So inhale through your nose.
you're gonna get a weak response. So the reason you get a weak response is that you're separating and then bouncing back. So,
Okay.
so you're gonna be doing the same correction.
Yeah.
That's all person who made jokes about it.
You guys the one that
She's like that.
Yeah, on my exhale. So it's like, wait, hold on.
She's way much better. Dynamic is also slider.
You work so low.
Dynamic versus static. Static is I just go here and I hold it and then pass.
You know what? When I
Dynamic is like pull apart, release. What's that? No, did you guys find it? Did you find it? Static.
Yeah.
Medical is really good.
Yeah. I have one for me. Okay. Yes, I have like one. I think I go past.
I think that when I learned,
Those are 24 years old.
They might got part of it.
Yeah, try to keep up with those lines. When you're doing that. You should try it.
Never seen one.
Alright. Who wants to have the brain?
oh wait, inhale through your mouth.
Make a liar out of it. Hey, don't breathe in.
Okay, now exhale through your mouth.
They're stuck.
No.
I don't have anything.
So you would correct.
Can I go back to the other thing?
So we're dynamically correcting it too. Good. A lot of times we'll feel the skin move. You want to have just enough pressure where you're actually feel. The skin is
Surprise, you know.
there's too much pressure and the skin will start to get
I think it's an acupuncture.
So I go right here if I do this. Yeah, it's like first here and wait a little bit and then.
Sorry. What is this? He's like, these chairs.
Give her a couple more.
One here. Nope, and here. No, you're
He's a son.
Well, this is the yes, but maybe that's what we did yesterday, like the L4. Oh. So you can try doing this because the suture is. We can't.
So what was your favorite?
So,
Do you trust me? I think it's I love her.
You just had well, when we were doing the yoga, whatever stuff was that, I really could only go back and like this is just a tail. But then what other stuff? Yeah, I thought it's not here, it's like back here.
Yeah. Yeah, I feel like when I try, if I'm weak, like when you got my legs yesterday, they were from I do love that. Well, now I have my sister and brother, and then I already know I I feel I can feel it. Yeah, and then there's I'm also I'm assuming mine to be weirdly. Yeah. It sounds cool when he's from oh, you got it? No, I didn't start. Oh, yeah. You know, I'm gonna be a student like I need to get that periodic so when I can fight which I'm just yeah, so push it. Yeah, yeah, and then I was like, this year now. So yeah. I was only taking a picture at 9:30. And then a few quarters were like, I was here for like I didn't feel it. No, it's okay. Yeah, we got the worst schedule. I never ended up. I went there to latch the go, not the latch switch time. I'm not surprised. I'm not surprised. She was on time for us, thank God, but I will walk out. Yeah, because I was okay, so like I run wow. The trail makes it back. It's not gone yet. No, I know. Honestly, you kind of saved everybody's life with that. So. I mean, everyone was like, you know, hiding over there. Yeah, quietly go to a restaurant.
And then she was I mean, if
Well, if you're doing a bunch of things, you go back and then you get other things that all address some of these kind of recap. What you
you are getting a cigar free.
Are we gonna get in our room or not? Does anybody know?
I haven't heard anything from anyone, so.
Wow, okay, so we might be kind of stuck with this environment for a bit.
Windows are nice. Yeah.
It's not bad.
It's worse.
Got a view.
There's a bright side.
Now, we want to recap or debrief on the development. Several of them had a glabella. I mean, how many had a glabella themselves? Good Lord, 1, 2, 3, I mean, everybody. Did you have a glabella? Yeah. So, pretty much, yeah, they're very, very common. Who had sutural faults? Anybody not have sutural faults? Anybody not have them? No, everybody has them. So, look for this stuff, you'll find it all day long. You, a couple of questions that I think were, so to recap the glabellar fault, 2 ways to, how would you determine that you want to look for it? Several ways. One is, you have a weak muscle that you determine through using pulse points or TS line. So some of the newer techniques we're learning. You found a weak muscle through posture. You have a weak lat with a high shoulder. Now you want to know, what does that muscle need to be straight? So one of the things you're gonna do is you're gonna have the patient breathe in and breathe out, breathe in and breathe out. If that affects that strength of that muscle, you've got a cramp of some kind. The first ones we learn are inspiration assist and stimulation because they're pretty common and they're pretty easy to fix. So a lot of times we go with that first, a lot of times it clears the problem. With glabellar faults, a lot of times something still isn't right, so you keep going back. Well, if you fix the inspiration assist, but then this cranial thing keeps coming back, checking for a glabellar. And the unique thing about the glabellar is the breath in and out, nasal versus oral. That's the signature finding. Just like temporal bulge, what's the signature breathing pattern for temporal bulge? This will be on your test, guaranteed. Half breath in.
Oh, that's right, half and half.
Strengthens a weak muscle. That's temporal bulge. Now, half breath in will also weaken a strong muscle with a temporal bulge. But really, you want to verify it both ways. But usually, you're going to have a weak muscle that strengthens on a half breath in, not on a whole breath, and but on a half breath. That's a temporal bulge. Bridal descent, which is the other half of the temporal bulge pattern, is going to, weak muscle is going to strengthen on a half breath out. So you have to breathe all the way in, half breath out, and that's kind of tricky. But know that for your test. Guaranteed that'll be on you. So glabellar fault is nasal versus oral. Temporal bulge is half breath in, half breath out. Inspiration assist is just breath in. Spinobasilar is forced breath or forced breath out. It's almost always an in. That's the signature pattern with forced breath in. How you determine which one you go after, sometimes you just got to chase them all and see which one.
So you can use the same muscle. You find a weak muscle and you're like, okay, let's check cranials.
Absolutely.
And then you just chase it with that same muscle all the way through.
Absolutely. You can also TL. That's where I don't mention this enough, but you can also go straight to TL. If you suspect so you know it's a cranial, but you're not sure which. Have them TL right here at that mastoidal occipital line that we were just calculating, that slow sulcus. That will, if you've got an inspiration assist, that will positively TL. Now, if you you can TL sagittal suture, but remember what group of muscles does it tend to cause to go weak? The sagittal suture. Rectus abdominis. And then the coronal. So if you have a patient, and either from posture or some other mode of testing, you determine their abdominal muscles are weak, that's a good time to test them. So if I'm testing abdominals on a patient, usually they're a low back or something, I always check for breath in, breath out if they're, and they're usually always. I find weak abdominals all day long. Sometimes I'm just tired of looking for them because they're so prevalent. But so those are the things you want to know about the different. Glabellar fault also, it's believed there's a corresponding sacral fault too. That probably won't be on your test, but it might. Remember, there's a sacral fault associated with the glabellar fault. Often, innominate, like a PI or AS pelvis will go along with a spinobasilar or inspiration system.
That potentially be because of the low.
That's one good explanation. Love it, the torsion relationship, the way the spine organizes itself with itself. It's off, and that's kind of, I think that's one good explanation. The other thing too with glabellar is if you have a blood pressure patient, which we're all going to have blood pressure patients, you probably already do in clinic. If you have a blood pressure patient, check them for glabellar. Takes no time at all. Just do a quick TL or have a breath, breathe in, oral or nasal with a strong indicator muscle. I mean, you could do that in 20 seconds. You can tell if they've got it. I don't know, in clinic, you have to let you do other questions on.
Some of the docs are okay with AK stuff and doing that somewhere.
I think of all the cranials, glabellar makes some of the most sense as far as why it causes split. Now, the last thing I'll mention about glabellar is, so always think blood pressure, glabellar. Things you want to have. The other is TMJ. When you have someone with a TMJ issue, think a lot of things, but also think often that, especially at the bilateral hypertonic temporalis muscle, it's going to create that. Basically, you think the skull is being kind of squished. This temporal bulge is when you have, excuse me, when you have a unilateral temporalis. That's going to cause parietal descent on one side. It's going to cause a temporal. So TMJ can cause a lot of different things. Dr. Francis didn't really like even teaching cranials because he thought all cranials were a result of TMJ and gait issues, which he was hard to argue with because it makes a lot of sense. But he really thought cranials were they were the result of TMJ problems. Fix those and then keep the cranial. Of course, they don't always. Sometimes they've been in there long enough. Even if you fix the other things, it takes a while for the cranials to normal. I've got people with temporal bulge. I've never been able to. Their heads have been like this for 20 years. I treat them and I kind of normalize things for a while, but often they have an anatomical short leg, kind of chronic category 1 pattern. They're usually people who are chronically eating or drinking something that their body, their immune system is doing. That's kind of a classic thing. A lot of times, get them off something that they're eating 3 times a day, that their system is reacting. A lot of times, those patterns go. That's pretty amazing when that happens. Same with ICV. Get them off gluten, for example, if they're really gluten intolerant. The ICV problem just vanishes. It just isn't there after. The gut lining turns over every 4 to 6 days. So changes in the diet and changes in the way the immune system is operating can see changes in the way the body's functioning pretty quick. So the body's renewing itself all the time. Shall we jump into shoulder? Now, somebody had shoulder problems.
Can I ask a question before we switch?
Oh, I'm sorry. You had your hand up.
No problem.
Yeah, go.
Have you found long-term results? Because you mentioned if you have a patient with high blood pressure to check for glabellar, they need it corrected. Have you found that results in long-term significant or even minor change?
Not unless they make minor change.
Okay.
If
So
they're,
the idea to just correct so that they have a better baseline starting point
Yeah.
for healing.
and there's the value in those kind of, I mean, a lot of the stuff we do, face it, a lot of stuff that's done in healthcare is short term. It really is. It's a lot of stuff is not going to create long term treatments. Part of that is that people keep going, exposing themselves to the same biomechanical stresses, chemical stresses. They're always needing to be set. But with things like blood pressure, there's a multitude of things that cause blood pressure to go up. One of which is nervous system's attempt is not able to get the blood where the tissues need. So it's amping up the pressure to do what it's designed to do. So usually they need to, if they're on tobacco, they gotta get off that. If they're, sometimes these people are drinking way too much caffeine. But you gotta look at all the other things. There's, of course, the familial blood pressure thing, and I think that's kind of overplayed by the medical profession. You know, they're always relying on this, well as genetics, you know, without actually looking. I think that's probably a small, really a much smaller percentage of it. It comes down to neurological. It's just like blood sugar. It's really body's mechanism for managing blood sugar starts to break down, and it loses its ability to keep it. Same with blood pressure. Structural causes, glabellar fault causes blood pressure to go up. So if you eliminate that, and that's all they got going, their blood pressure should stay down. If you see a glabellar fault, you've got a TMJ. If you've got a TMJ issue, you might have a tooth issue. If you've got a TMJ issue, you probably got a gait. Of course, we're under TMJ. Does that answer your question? No?
Yeah.
My experience is kind of all over the place with blood pressure. It's really difficult to get people off of things that I don't push it. I used to. They're addicted to sugar, they're addicted to alcohol, they're addicted to everything imaginable. Emotions, more than anything, they're addicted to the same patterns of response. People quit their job and their blood pressure drops 20. I've seen eczema, I mean bad eczema. I mean, we're talking nasty, thick eczema disappear. This guy years ago, he was a patient of mine. He worked for the sewage treatment plant. And it wasn't like he was exposed to sewage that much or anything, but he hated his job, just absolutely hated it. And he had a boss that was just didn't get along with him. He quit his job, and they just freaked out and quit. I watched his eczema vanish. It just disappeared over a period of like 2 months, 3 months. So that's all he did different. He didn't change his diet. He didn't do anything different except he got out of it. Body doesn't care so much how long we live. It doesn't care. It doesn't care how we look. It doesn't care our innate intelligence. It's involved in keeping us up. Digesting that. And it's our ego and all of other abstract thinking that is so concerned with living long and all this future abstract stuff. It's our body is dealing with, like right now, my body doesn't care about any of this. It cares about keeping me upright, not falling over, making sure enough oxygen is getting to my brain. And if a system starts to break down, then the other systems will support and do whatever they need to do faster, upright. And so that's how we end up with postures like this. How we end up with kinds of things. Body's doing what it does best, and that's living in the present. So shoulders, there's all kinds of conditions that you're going to see. The world of healthcare is so proud of themselves naming all these things, but often naming something like shoulder bursitis doesn't really do much to explain how this hangs at. And I see so much in the way of shoulder and hip. that are being treated with injections nowadays. That's kind of the go-to. A lot less surgeries are being done. They're injecting people with steroids left and right. You guys, any of you learning to do therapy?
Hmm? Yeah.
You guys get that here?
Yeah.
Are any of you doing it?
I've done it before.
Yeah.
I've received it. I haven't.
Tell you what, that's a very effective technique. We can't do it as chiropractors because we're not allowed to do that. We can pull blood out, but we can't put anything in. Yeah, there's several naturopaths in my area that do. There's some osteopaths that do. So let me have somebody come up here with own shoulder. No. Have you
I
injured?
do it. Yeah.
Okay, so how long ago?
This one was probably in the last 6 months again.
Doing what?
Rock climbing.
Oh, okay.
I've torn them all up years and years and years.
Somebody must have been chasing you. You have to climb a rock.
It's more of a dare kind of thing. I bet you
love
can't.
climbing gyms, but I take my
And
granddaughter.
they were right.
My granddaughter said, I've got them into climbing. No, we couldn't. My daughter told me that, then now they want me to join one of we have a really nice climbing gym. I told my daughter, and she said, well, you get them hooked on this stuff, you're gonna have to pay for it. They're kind of expensive. So now I've kind of, but they're really fun to go with, so.
So fast.
So right shoulder.
You just choose which one, right?
So here's-
last injury.
Here's how I approach a shoulder. Person comes in, my shoulder hurts. First thing is I do is say, what can you do with it? Tell me what you can do. Now see his neck? First thing he does is, what's he doing? He's trying to facilitate his upper track. Try to get more out of it. Now if I hold your head like this, go ahead and lift. Okay, now I'm not gonna hold your head. Just lift your shoulder and do it.
Where?
Yeah, I know. If you really go, you can get a few more degrees. Now, a lot of times too, they're sitting like that, and I'll straighten them, and now lift your shoulder. Sometimes that's not a huge difference. So then I'll look at passive. Now his active range of motion is right there. That's pretty. Now I want to see his passive range. Is his passive range? He's a little tight. It's not bad. Okay? It's a little tight, yeah. Then I want you to touch your back. This is all standard kind of work. That's not too bad. You want to see if they can touch here, that's considered pretty good. Then you always want to compare the other side. Show me what you got here. Well, yeah, go ahead and do that. One side's usually going to be a little bit. Yeah. Right-handed?
Ambidextrous.
Oh, okay. I know. His passive range of motion, nothing stands out. But the reason you want to check passive range is you want to feel what that shoulder is capable of doing before you start testing on it. Then you want to bring it up into this position. These are going to be your test position. I'm looking at, that's the internal rotation. A lot of times that's a little tight, but not terrible. This way. That's not too. Now, we go into, this is, what muscle will this be? Just learned yesterday. Infraspinatus. See, that tests really good, but, there you go. Something I find very often, I'll usually do this, it weakens to a stretch. The infraspinatus often is too tight. And now, here's his internal rotation. Not terrible, but you come in here, what am I doing to those infraspinatus? Spindling it down. Autogenically inhibiting. Not facilitating, so I'm pushing them. And then you go back here, see that? That's 20 degrees here, again, just from doing that. So a lot of times if the subscap is not firing really well, it's because this guy's too tight. And sometimes this guy's too tight because the subscap's not firing. So I'm going to test. The infraspinatus is actually weak. And then I'm going to test his teres minor. I always try to do all the rotator cuff muscles first. That's pretty good. What's the other muscle we learned yesterday? Hold that. That's weak. Here is, what's this muscle? Monitoring the scapular motion. What's this muscle? Lower division, right? Everybody's good with that? No division or division, right? Supraspinatus, not quite as much external rotation. Little wimpy. So we got a weak infra, we got a weak supra. Teres minor, it was good. And we didn't check deltoid. It's actually good. Posterior deltoid, not so much. So then I'm going to go, and I'll test these on every shoulder I work on. Test every muscle that's involved in that shoulder. What am I testing now from yesterday? Ooh. So there's weak. Somebody keeping track of this. Coraco, infra, supra, and posterior deltoid. Okay, so we're going to test. What am I testing now? Pushing out. Pec minor. Anybody else? Agree? Pec minor. That's a little mushy. There, push it. I'm testing now. MC is correct. The MC. And how do I want to test the PMS? Opposite and starting position is the same, vector is it. So EMC mushy, Pec minor mushy, Coraco mushy. What's left? Rhomboid, go around back. Turns away. I'm looking for scapular motion, just like I am with serratus. And that's good. There's nothing moving there. Drop that down. What am I testing now from yesterday? T-beta. It's a T-beta. Beta, maybe. No, that's not too bad. So, left. Shoulder up.
Do you want to test like the long biceps?
I will. Definitely. I'm going to test. I'm going to be heading down there in just a second. I'm going to check the upper trap. Stretch. I want to see while I'm at it is the upper trap hypertonic, and it is. So it tests strong and clear. Remember, that's the signature thing of the hypertonic. Test strong and clear, weaken that for temporarily. Strain, counter strain muscle. Be like a synergist to the primary weak muscle. Strong and clear, weakens after a full 6-7 seconds. Strain, counter strain, which is often found as a synergistic muscle in primary. We don't know what his primary weak muscle is. Got a bunch of them. So I need to pick a couple and see what might be effective. Now, this is how I would do it in the clinic, but bird, and then we grab it. So I want to see if he's got neck control. Now, I might have already tested neck muscles. I'll take through here. It's a little ropey down here. Now, this is how I test. Okay, so we learned yesterday long head bicep test this way. Long head tricep test this way. Now, what I've found is if I test the long head tricep this way, I get more information about the break. Hold there. That's me. By testing this way, that's fine. I would say there's nothing wrong with it. But if I test it this way, which is actually the way we use it, if we're doing something in the real world, we're going to be using it this way, right? And that push down. That's weak. So I'm gonna go with that because I know it's really simple. So his neck right now is a little bit anterior right here, C5. Yeah, which is, here's what's interesting. Right-handed people usually will have an anterior right. Or C4, C, did I say T5? C. Left-handed people often will have it on the left side. Now, left-handed people are only, what, 7-8% of the population. Anybody else in here lefties? One lefty. Look at this. And if you're ambidextrous, I'm sorry, you're left-handed. You were born left-handed, you grew up in a right-handed world. So I'm going to bring you over this way. Just like that. That's reducing the C5. Now let's go back here. Let's test the posterior delt. That turns on. Let's test the long head tricep. That turns on. We had a bunch of stuff here, coraco, and MC. We had pec minor. Everything was turned on. What didn't we test? Oh, upper trap was fine. Second weekend. That one will probably just. So, am I going to treat his shoulder first or his C5? Now, I think I got a C5. Am I sure? Let's go to the other side of the body. Not a real. Make sure he's not going into correction. Okay, let's do this. Now take your other hand, bring it across. This might give us a cleaner. Fingers flat. That's a cleaner response. Now sometimes it's not as much anterior as it is lateral. So he's got this needs to be adjusted in right rotation and probably a little bit of right lateral. It may, with anteriorities, a lot of times it only TLs in the front. That's why we miss them a lot. The posterior, set jamming kind of typical stuff. Touch here with your. He's not really TLing at that level. We could go. It's good to TL all over. Just get a lot of patient. Right there. So now, if we TL that and we have him go back into this corrected position, it goes away. So that's a typical. I do this all day. I do this probably. I'll do this tomorrow at least twice. I'll this guaranteed.
Is there any way to adjust that without?
You can do activator if that's your thing. I have two Arthur stems. Actually, I have one. One of them really well. And I have a percussion. Not a huge fan of activator. I think it has its place. I use my Arthur stem a lot on old people and people who are freaked out about me. And I've used it on a few animals. Sound bothers animals. So I'll correct it using respiratory. I think respiratory, osseous adjusting, if appropriate, is probably should access the most neurology, you're having the most effect. If it's done right, and if the person doesn't have liver infection. Probably second to that would be, in my opinion, would be respiratory. Because you're still basically, like when I do this adjustment, we'll see right there. I'm going this side because we tested this side enough and we know we have a bunch of these muscles here. I'm going to challenge him as if he was a P to A. Now, I'm going to challenge him as if he's kind of lateral. Yeah. I'm going to challenge him if he's lateral and anterior. I'm going to challenge him again. Breathe in. Hold your breath. And that's what we want. Breathe in and then. So I'm going to correct him. Get right on here. It's pretty simple. Lean back. You already know that this is where his system wants. Breathe in. I might sometimes do this and then go in and just do a very gentle osseous, make sure I cleaned up anything. If there's adhesive elements around the sets, around the intrinsic muscles, then a lot of times the osseous adjustment is really necessary to really clean that out. That's where I find myself in conversations with some of my colleagues that are, I had people try to convince me that they can do anything with activators. Just, he still needs a little bit of adjustment. Let's see what we got. Push, push. That's cleaned up. Push down. Push. Ah, that's still not there. We didn't get it. So he's, yeah. He really needs it. Let's see if we can do it. I just want to do it. See if I can. Breathe in. Breathe in. I'm right on that vertebrae. Right on a bunch of stuff. I'm right on his vertebrae. There we go. Sometimes you just got to get in there and really. Okay. When you see these people doing the respiratory corrections, you'll see this if you go to the ICAK stuff and watch the demos. They're doing these little, yeah, and it's like, yeah, I'm not convinced. I mean, yeah, they'll get changes, but you know, you got to really address the tissue. Let's see if we got it. That got it. That got it. I got it. Now TL that again. Actually, let me read it. So we have no TL. Breathe out. So that's good. So now what? Remember this one? That was a particularly concerning muscle because it's part of rotating. This one was good, didn't wreck it. Supraspinatus. That one's totally back on. PMC. Coraco. Bring it a little bit bigger. Oh, somebody, long head biceps, right? Hold there. That's kind of the classic way. Bring it out like that, hold. And that's strong. Now, we didn't check that initially. We should have seen it. It probably would have been related to that too. Take a fist. That's the way to really test if you really know you've got whole kinetic chain. Now, take this hand, touch right here. Now, when there's an anteriority, lower cervical anteriority, which often will be associated with a cervical disc. I often find a category 2, just to see them all. So a lot of times after I've done that, then I test for cat 2, and he has it. So if we have him TL his right SI, that goes weak again. What's that? Heck minor. Everything goes out. So I often have to do a cat 2. Now, sometimes I'll do the cat 2. I'll put them on the back. I'll do the cat 2 well. But we can't really do it. We'll do a cat 2 on you later. Now, without him TLing that, he's staying. Let's use this one here. He's staying solid with regard. But if you go walk around, be like, yeah, go walk, take a little walk about.
Doctor, how you find the physical body and that makes the weak muscles go strong like that? But
The thing I go on is I'll probably saw me. I'll palpate the neck. Tell a lot of times that where it's kind of feels a little, and you can start with that. Sometimes you don't know. Usually, so if you're looking at brachial plexus on the right or left, on the right, this position is going to slacken any tension on the brachial. It's going to lessen any tethering. So a lot of times, right rotation sort of slackens that, opens it up a little bit. Then if you laterally bend them, it opens up. So you just kind of think that you know your biomechanics from there. It's not like there's not like a hard cast, group of steps. Had him all tuned up here. That went weak. So all my fancy work is for naught because we didn't fix it. Now, if we could go back here and comes right back. So this pattern, the pattern just came right back, which involves this. And when we get access to a table, what's that?
P5 still in.
It should stay in for a while. It'll take a while to knock that. Do it, I know. I got faith in you. Big it. No, we got that covered, yeah. So you might have to walk a lot. Eventually, if he takes a nice long walk or say goes and does some gardening, that will probably be. Oh, whatever. Whatever you people do. Us old people, we garden on the weekends. Unless we're teaching. Yeah, thank you. That was excellent example of how you think you got it, but you don't, because you didn't do all the stuff. Category 2s are super important. Category 1s are super important. And if you just get really good at Cat 2s and Cat 1s, Cat 2s especially, you'll fix so much stuff. You'll clear a lot of smoke out of the room. Someone else come up with. Now this was the snowboard.
Yes.
And we had IRT pattern. We actually did it twice. Let's just. Yeah, we didn't push your job. That's. And try this one. On head, and then we'll do it the classic way. Let's try your pet. What was the yesterday? Corticolis. Yeah, see, that's rock solid. So, serratus. That's good. Now, remember this one we learned yesterday? Something. You probably, most of you know it, but the first one I hear is the one that I think. That's good. So I'm not finding, well, rhombo. We had a rhombo.
Yeah.
And that's not the levator. No. Trap. Oh, yeah, yes. Yeah. Maybe you don't have a shoulder problem. The IRT thing, that's why it's so powerful. I'm just not finding it. There gotta be something going on. It's long standing. Now take your hand. He's got emotions. We don't know why.
I do a lot.
Let's see. I don't want to do it. Let's just see. I want you to close your eyes and just think about the snowboard. Yeah. Yeah. So, I mean, that falls on skis. It's traumatic. I mean, I had a fall that I almost decided every time for me to ski. It's about 4 6 years. Nasty fall. I hit ice, and I was usually when I fall, I just sort of spin out and slide and stuff. It's fun. This was one of those things where I was coming around and I was hitting some ice. All of a sudden, I was absolutely deep. My skis were over here, and I was in a snowbank, and I don't know how I got there. I felt really jarred, and I was skiing alone. For some reason. I finally got my gumption back up, got my skis back on me, I didn't even want to get back on the slope. I had to get back. So it was at Snowmass, Colorado, way low. I had to take like 2 different lifts to get back. I was like feeling kind of panicky. I was fine. I was at a chiropractic thing at Snowmass, and so I got treated that afternoon by Dr. Wally, and I was fine. But I really questioned whether I should be skiing. Over it. But, those kind of falls, and that really, when I hit ice now, that fall, I've had a few other falls. So I knew not only did you fall, unexpected, you actually hurt you. So those things really. Car wrecks, which something, since we have you been in a car? Anybody been in a car?
Right there.
Mine was really recent.
Okay,
Hers was like super recent.
mine's not that. Okay,
Mine
so
was like 5 months ago.
5 months ago.
Yeah.
Rear-ended?
We rear-ended somebody.
You rear-ended somebody else. Anybody else got rear-ended?
Lauren. Lauren.
Oh, yeah.
Oh, you got a bad one.
Yeah, total full cars. I got hit on the left, I guess, tail light, basically. And I had my seatbelt on and my head was turned to the right when I
How long ago was this?
last March. Or like not this March.
So March 24th? 25, 25. Okay, so a year, only a year.
And it still hurts.
Okay. I'm sure you've been treated.
Oh yeah, we had like, I did 12 weeks of chiropractic and 12. Coming back to like 80%. Sorry, we can't help you.
Sorry, everyone's cut off.
You're in car.
I said, sorry, internet's cut off. You're what, 24 years?
A lot? Like, how's people, how do patients go, yeah, car wrecks. I'm like, plural? Car wrecks, can a person get in? You know, were you driving? Oh, man. And you were in a car wreck? Oh, you were. Okay. Were in it? Just once, or
That was only, yeah,
how long was that?
November.
Oh, recent.
Yeah. Down.
You were rear-ended like that.
Oh yeah, I hit on the wheel. First, but
That, okay. So, rear-ended.
I have, but my shoulder also still.
Softball. What about car wreck? We're not going with shoulders, I promise.
Car wreck, but actually fell asleep during the middle of the day.
And you were pretty recent.
Yeah, it was like the beginning of this year. We hit somebody on the highway and almost got rented. Thank God we didn't. Then we would have got smashed.
You're Oreo.
You? Rear-ended? Did somebody else?
I was T-boned one time.
You guys
Oh.
are rough bunch.
I wasn't driving. I wasn't driving.
You're so quick.
Dean and I were talking, it seemed like you were saying that car insurance is more expensive here than it is. Oregon.
Yeah. If you haven't been in a car accident, move to Phoenix. You'll get one.
Why people drive this equipment?
Sunburn and whiplash. So
Les,
special.
did you ready to have a car accident?
Yeah, I was.
How long ago? Of all of you who've been in car wrecks, how many of you have residuals? How many of you still have residuals? You don't feel like maybe you have residuals. Let's take a look at you first. NPT, you've had adjustments, had probably NET, all kinds of things. Okay. So, what would be your symptoms?
So yesterday, cold fixed. Like it was, elevator scalp was really good, and I was basically going like that.
Okay.
But I also think that there may be like being found a potential basal tear in this shoulder, and I do definitely have like range of motion compared.
So lateral tear, I mean, the long head biceps test is, first thing I do is, even before I do range of motion, I'll take and I'll just loop the GH joint. I look for spring. And sometimes patients are surprised they've never had anybody do that, and they go, oh, was it supposed to move like that? I said, yeah, it's supposed to move. If it doesn't, then this one is just a hair tiger. Now, some of them don't move at all, but then we know we got issues. They just don't move because they're sucked up so tight. Let's have you bring your arm out this way. That's pretty good. That's actually very good. So did you fix it? You must have fixed your muscle. What made you just suspect that? Lateral tear.
He did some putting yanking on it.
You missed something.
This makes it sound like a little more than I just was like fling her around by her arm. Yeah, I think we started thinking about it because we think whiplash is always like the neck, but we always forget about the shoulders wearing the seatbelt, right? And so that's kind of where we were at, and she was looking the other direction. So when we started putting her body in the hack position, then the joint just showed right
So
up.
middle, somebody either help me remember which muscles we're finding here. So middle division serratus is vertical is MC is we. MS is we. Very minor is. So at this point, what do we think from like section 2 or 3? Shear contraction. All the muscles around that joint are weak. Now we'll go back to that, but in the meantime, let me. I won't do. You've had a lot done to your neck, so I don't. So right there, you asked about how I determine. Right about here feels like it's a little on the left. C6. So I'm gonna. What I'm doing is I'm feeling for when that vertebrae just feels kind of happy and right there. So that brings that right. And that brings it. That's a good thing. And that's better. Just something else. So the pec major clavicular seems to be reluctant to turn on. Trying to. Okay, so if I suspect I have a compaction here, what a bunch of muscles weak, except for one maybe. Have we found one that's strong? None of them are strong. Probably rhomboid. Long end of the bicep is strong. Yes, right.
Feeling was weak.
The rhomboid is good.
I mean, Vader.
The Vader. Okay. Let's test your scalenus. That was scalene. So SCM on the left. Scalene's on the right. Touch your right SI. Now, so she's got a little, probably a tattoo there. Can you touch your zygomatic suture? Can you really find a zygomatic suture? If you came back. So I'm going to go back to this compaction thing because stretch it. That's the torque. definitely a compaction. Now, this one here, hold it. That's strong, but I'm gonna ask you to do. I'm trying to tweak its energy just enough to see if it'll. There it is. So that's what we would expect. So it's hard to get on that labrum, but get up into that bicipital. Get right on the in that bicipital groove and just kind of clean up around that. Can get tender. Clean up around that biceps. The bursa there, I just had to kind of. Now I'm down into the actual muscle. Just going to do an envelope. And then remember, O and I is usually the main. Insertion. So that might reset at least for now. Then we have this scaling issue. Still there. Even through your nose. Has anyone done a stenobasalar on you? Can you find me a glove?
Oh,
Have you
yeah,
heard from
room.
these Yankees about our room?
No.
Atypical. Atypical. I'm gonna do a.
Well, usually we can get into 7. If we get into the other building, all the power's on and everything runs normal.
Well, how did you determine?
But it still kind of smells.
Well,
Getting better though. So you got those on the side. Yeah. That's what we got. We went and checked to see if we could use the room.
I don't know, I think he bought them at the car. Like something with my car, I guess. So now I have to go.
So,
I didn't change it because my car, there's nothing wrong with it. It burned. Like my car.
so she strengthens, scaling, strengthen on the breath in. Time. Full breath in. Forced inspiration, speed over. If I need to TL, I could, like a TL or palette, but I'm not gonna just go straight. I'm gonna seat it. That's kind of the situation we got here.
I don't mind like that.
It's not actually. Plus, I mean, you guys have been treating in the RF position. So, actually, before we do that, let's try something here. Let's try this. Now, I want you to go into driving position.
Like driving position normal or driving position when I got there?
Well, you were turned, right?
Yeah, I was turned. I was turning away.
You were trying to do
I saw it happening before it was happening and there was nowhere to go.
Drive along straight back because you wouldn't sit.
Oh no, the people in front of me are stopping. Right, right. All right.
That was really good.
So let's. Unique work experience. And have to look at in the position. Put this in. So, have you done, anybody done IoT?
Not recently, but
Okay. So, I'm gonna do an IRT on this skating area. This went on. Now, it's above G6, so I'm just gonna pick top split. Instead of flicking the ankle. So turn again. That made a big difference. Okay. After that, I want you to just close your eyes. Just to think about So I'm going to do right up in services. Could be. Certainly, this pattern is there. The system is running that tape. So guys, breathe in, breathe out, all the way up. Still going to do this thing base. First expiration block. Are you with me? You're either with me or against me. So how do I do a skewer base? You tell me. Where's one hand go? So I'm on the mastoid, basically mastoid sutural area, mastoid occiput. Then I usually use my index, my long finger, and I go just to the right of cruciate suture. And I'm going to have turn. So I want you close to the position you're in. As she breathes in, I'm pressing on the third palate, access the sphenoid, pressing forward on straight. That lift a little bit. Okay. much as you can get. That clears that. Now, you also hurt the seatbelt came across.
Yeah, it was like.
So long head, let's see if it's. So, it's all the way up. I just walked by their official looking guy.
Yeah.
So subclavius, she goes subclavius at TL. Now, what do we do with the subclavius? Same thing we do with any other muscle. At TL, it's weak. I'm going to go in and spindle it up. And it's a small little muscle. It attaches kind of underneath on the inferior edge of the now I'm going to go to this we had a coracoid, brachialis, and a pec minor leak, and both attach. Same. There we are. Sorry. So that. So before we had that turned on, but if I touch the origin of it, it turns off. So it needs ONI. Guys, I'm trying to integrate all this crazy stuff we've been learning the last however many months. 6 months? I would suspect that. Scalenes, attachment up here. We didn't do too much to your shoulder. We did more. Yeah, we see how that does. We'll see if that C2 wants to hold better. So we're talking about whiplash. We're talking about anteriorities and spine affecting brachial plexus. We're talking about the shoulder. Can't really work on the shoulder. So who else had a? You. Let's check you're more of a freshman. You hit somebody else. What do people in the East Coast call the freeways highways?
Oh, yeah.
And we call them freeways. We call them highways. Highways like paved road. All of Jamestown. You take the highway? Okay, so do this one and then we'll are we gonna get to move into our room yet? Right. So Jennifer hit someone
Pretty fast.
fast.
Yeah.
So is that
Or
gonna
like
be
this.
it's
Yeah,
a different
there.
kind of whiplash. And with
I
that one,
wasn't driving either.
we're driving.
I was a passenger.
Okay, so yeah. So then, of course, we're thinking, posterior cervical muscle. But we're going to check all of them. And do you have shoulder pain?
Not that I know.
Any numbness in your hand? Head forward. And hold there. Test your scalene. They're the most commonly injured muscle in a whiplash. That one's weak. We'll go SCM. We'll go. Okay, so the SCMs are good. Upper trap. We'll leave those stone under here and hold there. That's good. Trap on the left is weak. Back to the both. So both upper traps are weak. What muscle, what organ is the upper traps related to? What organ and meridian? Anybody else? Kidney. Could be. Now, since we're trying to integrate here, so what organ is and meridian is this muscle related? Lung organ, lung meridian. What about the coracobrachialis? Lung. What about serratus anterior? Also lung. Okay, so I'm going to use a strong indicator muscle. Oh no, we need a different muscle. Let's use let's try for adapting. I want you to touch your pulse points. Try the other side. Interesting finding a lot of heart, small intestine parts. Now that's heart, small intestine. Which one is it? We don't know. Oh, real light. Real light. That would be yang, which would be some small. So we know that. So we have a meridian to work with. We have a cranium. It's like your weak muscle. The weak left scalene. Breathe in through your nose. Out. Breathe all the way up. In. Now, breathe out. Half breath. And breathe. Hold that breath in. What am I testing for? Half breath out. Temporal bulge, private. So she got that. So if she has that, the small intestine came up, she digested. She has temporal bulge, she also may very well have a it was like superficial is young. So we know that much so far. So what else we got? If she has a temporal bulge, then she's got a gait issue. She's got a gait issue. She's got a category. What's the status?
Oh, they're in there.
They're in there?
Yeah.
What are they going to tell us?
I don't know. They're just like chatting.
Okay. Let's move in. I need a table. Just.
Literally, yeah. That's funny.
How long have they been in there? I guess we should bring our chairs. Somebody grab the skulls too.
Okay,
Oh, yeah.
All right. We're ready to go. It's cooling off in there. Hallelujah.